My name is Fouad Chbi, one of the nephrologists and kidney doctor at Mayo Clinic in the Jacksonville campus, and I'm joined by Dr. Sabar, our cardiologist, also from Mayo Clinic, Jacksonville. We're very pleased to be here today, and thank you for being here, and thank you for the PKD Foundation for your invitation. So hopefully over the next 35 minutes or so, we'll go over some cardiovascular concerns or issues in polycystic kidney disease, and particularly we're going to be focusing on the autosomal dominant form of polycystic kidney disease. And then towards the last 10 minutes, we'll take questions, and then prior to that, we're going to run kind of a case and kind of go over the different phases that PKD patients go through and why it's important to look into the cardiovascular and heart issues in PKD. So just as a disclaimer, this is for educational purposes only. And then both of us as speakers don't have relevant financial relationships, except maybe one disclosure is that I'm very invested in PKD, and this is what I do for daily living. So this is kind of my disclosure, but not financial. All right, so no need to introduce PKD to you as an audience, but as you know, it's one of the most common inherited kidney diseases, and particularly probably the most common inherited disease in general across all diseases. And it's leading to relentless development of kidney cysts, which are fluid-filled sacs that lead, unfortunately, eventually to kidney failure. And it accounts to about 5% of patients who have kidney failure in the United States, and maybe about 10% in Europe, as the diabetes is a little bit less in Europe. So as a natural history of ADPKD, typically we have very enlarged kidneys, very distorted kidneys that are filled with fluids and sacs. But then early on in life, the kidney function is relatively well preserved, and then later on it declines. So to be able to understand who has more severe disease than mild disease, we need to have other biomarkers such as total kidney volume, or TKV. And then later on, we use traditional biomarkers, which is the creatinine that gives us the GFR, or the glomerular filtration rate, which is the percentage where the kidneys are filtering. And then we also use the combination kind of all the time, but towards kind of the later stages, we use the combination of these biomarkers. Autosomal dominant polycystic kidney disease is not just kind of one size fit all. It's a highly variable disease where some of the patients would reach kidney failure earlier in life, and about half of the patients maybe in their 50s, about 3/4 of the patients in their early 60s, but some in their late 70s, 80s, and some would never reach kidney failure. So it's highly variable. In general, males would reach kidney failure a little bit earlier than females, and about 98% of males with autosomal dominant polycystic kidney disease would reach kidney failure by age 80, and about 77% would reach kidney failure by age 80, 77% of females. Now, as you know, it's an inherited disease, so you might have inherited either the PKD1 or PKD2 gene, and then within the PKD1, it might be there might be more severe mutations than others. So those are the changes in the DNA code that leads to the protein to be not functional. So PKD1 is more severe disease, but here I would like to show you that even if someone inherited a bad mutation, the PKD1 truncating mutation, they might not have a very severe disease versus kind of similar mutation may lead to a more severe disease. So there's a lot of variability, and even within the same family, some patients might reach earlier than others. So I always say each patient would have their own path. And the reason why it's such a complex kind of, and why there's a lot of variability is that it's a interplay of a lot of things. So it's really beyond what you inherited from your parent, or if you developed a new mutation by yourself, so what we call de novo mutation. It's not only what you inherited as PKD1 or PKD2 gene, it's also what you inherited as modifiers. So those are other genes and other things that you inherited in general that could affect how the mutation and how the proteins are interacting. It's also, there's something called epigenetics, where after kind of what the protein have changes even after what you inherited. So even a twin might have different phenotype or different disease severity in PKD. And also that's a big component that you might be able to control, which is what environmental factors can affect polycystic kidney disease. Like low fluid intake or drinking less fluid might lead to worse disease. If you eat a lot of salt, if there's high caloric intake, and obesity can affect the kidney function negatively and PKD negatively. So all these factors interact together to affect how big the kidney cyst and how many kidney cysts you have. And then also the thirst hormone called vasopressin, which is a very important hormone in PKD. All these affect all these different mechanisms on the cell level. So how the kidney are producing the fluids and how they're growing to form a cyst. And all those, we can see them when we see you as a patient. We see if you have early onset of kidney, high blood pressure, hypertension, or if you have a lot of cyst bleeding, blood in the urine, or cyst bleeding or cyst infections. And also we look how big the kidneys are on the CT scan or MRI. We have other additional novel biomarkers that all the scientists and clinicians are looking at to look at the severity of the disease. So what can you do yourself to help yourself in PKD? So mostly you would like to slow down the disease process. So although you inherited a mutation that you don't have control, but there's a lot of these environmental factors that you can try to slow the disease process. There's other things that you need to be aware of that come with PKD, so you can screen and manage those accordingly and appropriately. And you also can make sure that you advocate to yourself to get the right screening with your providers. And then also incorporate a healthy lifestyle. So whether you have PKD or not, mostly in your household, it's very important to incorporate a healthy lifestyle early on, especially with the kids being at risk of having PKD and not knowing if they have it or not. It's good for everybody to be very healthy and incorporate that on a daily basis. So PKD is a systemic disease, which means that although the main concern is the kidneys, where they become cystic or have a lot of kidney cysts and kidney failure, you're very well aware that the liver also can have liver cysts. And also these polycystin protein, or the protein that are abnormal in PKD, they're also present in the blood vessels, in the heart, and in many other organs, but we will focus on the blood vessels, particularly the brain blood vessels and the heart in this presentation. So what are the cardiovascular or the heart manifestations in polycystic kidney disease? So high blood pressure is a very important factor, and I'm gonna focus quite a bit on that. There's the defects in the valves sometimes, not all the time. There's also a higher incidence of brain aneurysms that you would need to be aware of. And then also the function and the structure of the heart chambers sometimes could be different in PKD. So the focus on high blood pressure is because it's a very common symptom. It might be the early symptoms that leads to the diagnosis of polycystic kidney disease. In general, as human beings, we tend to have more high blood pressure when we're mostly in the 40s, 50s, and that's when typically it gets diagnosed. But with PKD, it's diagnosed earlier in the early ages at 32, 34. Some patients even have high blood pressure as children. So 20 to 30% of kids with PKD might have high blood pressure. So there's a recommendation to check patients or kids who are at risk of PKD. So they have family history of PKD. So one of their parents have PKD, the kids, before they get screened for PKD, they need to check their blood pressure with their pediatrician on a regular basis, just as recommended to any other child. And then if they are hypertensive or having high blood pressure, they need to be treated accordingly. Furthermore, if blood pressure is not controlled, it can lead to worsening kidney function, and it might make that decline of kidney function faster. So it's really one of the most important potentially treatable variable in PKD. And it's very important for you as a patient to advocate for yourself and make sure that your blood pressure is well controlled, because if you see your provider once every few months or every year, they don't have that control to kind of make sure that your blood pressure is well controlled. So it's up to you to make sure that you're checking your blood pressure on a regular basis, you're following a good diet, you're making sure that you're getting the right treatment for your blood pressure. Now, why does the blood pressure occur in PKD? And sometimes, and many times, it occurs before the kidney function declines. So very early on in life with PKD, we might have high blood pressure. And that's because of a lot of complex interaction that the kidney cysts have been leading in the kidney. So the blood pressure is controlled by different variables, and in general, it's controlled by the hormones that the kidney secrete and interaction between the kidney and a very small gland called adrenal gland, which comes on top of the kidney. So these, between the kidney and adrenal gland, there's kind of an axis of hormones, mostly the renin and angiotensin, and it's more released because of the expansion of the cyst in PKD, the compression on the blood vessels in the kidney, which leads to a lot of growth factors and other hormones that leads to, mostly hormones that leads to the increase in the high blood pressure. So that led to a very large study that many of you probably have been in this study, or some of your family members have been in the HALT-A or HALT-B study, which looked at the effect of blood pressure control on the slowing of PKD, and also the effect of combining two types of blood pressure medications, and then the effect of lowering the blood pressure to a lower level. So this study showed, and it was a very large study, so thank you for everyone who participated, about 558 patients in just that one arm of HALT-A study. So in the patients that were able to reach blood pressure in the 90s to 110, so the low target, where their kidney volumes was, the kidneys were growing at a lower rate as compared to the normal target or the traditional target, where we try to achieve 120 to 130 millimeters mercury. So there's a potential benefit where you can slow down the disease process with lowering the blood pressure. And the reason why we really like the blood pressure to be well controlled is we try to avoid the complications of the high blood pressure. So having high blood pressure can, and if it doesn't get controlled, and if it's high for many years, then the blood chamber, the heart chambers, and the what we call the left ventricle, so one of the big chambers of the heart, can get thickened, and that's what we call LVH, or left ventricular hypertrophy. And in patients who have high blood pressure, and about half of them might have this LVH, but this is an old study, and now we see that it's much less. That's because we have better control and better awareness of high blood pressure. And we know that if we have thickening of the heart, that means the blood pressure was not controlled. And we know that this is combined with a poorer outcome on the kidney and overall survival. Other complications of high blood pressure include vision loss, if really the blood pressure is very high, and then 190s to 100 for a long time, or a brain stroke, or a heart attack, or blood vessel damage and leading to heart attacks and other blood vessel damage, in addition to worsening kidney function. And that's a general complication of anyone with high blood pressure, whether they have PKD or not. Now in PKD, again, we try to target a little bit of a lower blood pressure target as compared to anyone with high blood pressure. And particularly someone who's on the younger side and who have preserved kidney function with very big kidneys. So what we call the Mayo Imaging class 1C, 1D, 1E. So this is adjusted, age-adjusted kidney volume. So the patients who are at risk of rapid progression. And then if someone has vascular or valvular disease, we'd like to have their blood pressure on the lower side. And everybody else would be at 130/80 as a target. And that's an average. So the blood pressure can go up and down, but we like an average to be in that range. And then we like to start with either an ACE inhibitor or an ARB. So those are classes of blood pressure medications. So like lisinopril, losartan, and others. So either or, we don't usually combine both, because if we combine them, there might be a risk of higher potassium. And one of the HALT study, the HALT-B, showed that there's no benefit. We can do also a beta blocker, or then a diuretic, or a calcium channel blocker. If you're on GnRQ, we try to leave the diuretic to the last resort. And sometimes when the kidney function declines further, when you have advanced chronic kidney disease like stage 4 or 5, you might need that to keep your to keep you from building up the fluids, and also to control your blood pressure. So things that you can really adjust your risk factors for is when you have high blood pressure, it's important to look at if you have a lot of protein, look at the echocardiogram, assess for how thick the left heart size is, and then also look at your cholesterol and make sure that's well controlled, and having a cholesterol, the LDL or the bad cholesterol, being less than 100. So if you need to be on a medication, that's important to start. And then if you're smoking, hopefully I can convince you today to stop smoking. And if you're not smoking, don't pick up that habit. So those are the risk factors that you have control over, and you can gift yourself the health by by adjusting everything that you have control over. Now, if you happen to have diabetes, which could happen in PKD as anyone in the general population, it's important to control your sugars. And that's because of all the high cholesterol, being obese, having extra weight, having the sugars, having the high blood pressure. It's all going to affect your blood vessels, your heart health, and that might affect your ability to get a kidney transplant or have good dialysis later on. So you need to keep your heart health as strong as possible. Now, one of the biggest things that you can control is salt. And I always tell my patients, salt is your enemy. Do not eat salt and try to restrict it. So salt is hidden, and I'll show you kind of how it's hidden. But mostly there's a lot of studies that show that if we restrict salt, particularly in PKD, it's better. So for patients who've been eating more salt, it has been shown in the CRISP study, and many of you are in the CRISP study that followed the patients for decades and looking at the risk factors and why they have more severe disease than others. The patients who eat more salt, they have bigger kidney growth, so their kidneys are going to grow, and that's also associated with faster decline in the kidney function, and then reaching kidney failure faster and more often. So every 400 milligrams of salt a day can increase your risk of reaching kidney failure by 8%. So that's for every 400 milligrams. So we recommend to restrict to 2,300 milligrams a day. Now, there's a study in Netherlands from the DPAC trial that followed the patients, almost 600 patients for 4 years, and then they showed that the salt intake is associated with higher blood pressure, of course, and lower kidney function. But here the new thing is that it's not, so we always think of eating less salt is important to control your blood pressure, so that's very important. But what's also more important in PKD, it affects your thirst hormone, the vasopressin. So there is a test called copeptin that we don't typically check except in trials and for particular reasons, but mostly in clinical trials. And this trial showed that the salt intake affects your thirst hormone, and that's why it's affecting the kidney function to get to progress faster. So definitely restrict your salt. That's the home key message. Now, high salt affects, in addition to the blood vessel, the kidneys, the immune system, inflammation, the brain, and the bone. It's important to know that it's not only the shaker that's high in salt. So that's about 10% what you add at the table. The rest is all in the processed food. It's hidden. So it's important for anything that has a label in the back to look how much salt, sodium you're having in each of the servings and how many servings you're getting, and be aware of these. So when you're doing your grocery shopping, and if you have issues with or challenges trying to understand what's high and what's not, or you're feeling like you're not able to eat much, it's important to meet with a dietitian and have them guide you through the process. Now, the other thing that you can modify is how much you eat and how much you put on weight. And that's a challenge for everybody. And we're not going to deny it's very challenging to be in a normal body mass index. But let me show you a little bit of the data, and hopefully I can encourage you to lose a little bit of weight if you have excess weight on you. So another kind of post hoc analysis, so after the fact of the clinical trial, one of the groups has looked at the patients in HALT, and they looked at how fast the kidneys are growing and how fast the kidney function is declining. And they saw a big association between the weight or the body mass index and how severe the disease is. So for patients who are overweight or are obese, in comparison to someone with normal weight, their total kidney volume rate of growth, so how fast the kidneys are growing, it's much higher in overweight and obese, and the kidney function decline is faster in overweight and obese patients. So it's important to kind of try to achieve body mass index of around 25 to 28, 25 preferably if you can. Now there's a lot of valvular connections between ADPKD and having the valve being a little bit abnormal. So there's two terms we talk about is stenosis, where the valve is kind of scarred and it doesn't open properly. And then there's something called regurgitation or leaky valve. And so it is, as PKD is associated with both, mostly in regurgitation. So the mitral valve here, so with PKD patients, there's a high risk of mitral valve prolapse, which we mostly monitor. And then there's also a little bit higher risk of regurgitation. We also look at the tricuspid valves on the right side between the two chambers of the heart. And then also we look at the aortic valve, and there's a little bit higher risk of regurgitation or leaky valve. And then also our group has looked at all the PKD patients as compared to patients who have other kidney diseases like diabetes and other kidney diseases. We looked at their echocardiogram within 2 years of their kidney transplant, and we had about 271 patients in each of these groups, and we found that PKD actually have much better heart health as compared to someone with diabetes or someone with kidney failure from not diabetes and not PKD. So what I mentioned, that LVH or the thickening of the heart was only 40% in PKD patients as compared to other patients who are at the same age and same gender. So diabetic were unfortunately the worst group in this category. The mitral valve regurgitation and tricuspid regurgitation is also lower in this group. So it's a little bit lower than what the other groups have shared. And then also the survival of patients after transplant, it's much, much better for PKD patients as compared to diabetes or other kidney diseases. Then also patients with PKD had what we call MACE-free survival rate. So they had less strokes or heart attacks as compared to diabetics and other kidney diseases. So some good news for PKD patients is that although we're talking about cardiovascular challenges, they're typically healthier than other kidney disease patients, but that doesn't negate the fact that you need to keep your heart health as healthy as possible. Okay, and this is the same study, just kind of showing you a little bit more details that PKD here in blue typically are much better than at time of transplantation, much better in terms of the heart valves, and then as the heart function, so how the heart is pumping or relaxing also, it's much better at time of transplantation. And this is what I mentioned, that after kidney transplant, this is in blue, the PKD patients, they do much better and they survive for longer and much longer as compared to other kidney disease patients. And then they survive without strokes or heart attacks as well, and a stroke-free survival as compared to other kidney disease patients. Now, over the next few minutes, I'm going to show you a little bit about the brain aneurysms. So in general population, a lot of us are kind of living with a brain aneurysm without knowing. So about 1% of anyone in the world has that. In PKD, it's a little bit higher in chance, so about 9% overall. And then for someone who has a family history of brain aneurysm, so if one of your family members has an aneurysm, then you're a little bit at higher chance that you might have it as well. So it's important to get screened. So I'll show you who we screen usually. And unfortunately, it's associated with a little bit of higher death in PKD patients. So it's important to have that screened and taken care of. So when do we screen for aneurysms? So so there's no clear guidelines. This is kind of expert opinion. As age 20 to 65, would like to screen if they have someone in the family, if themselves had a brain bleed, if they're going for a big surgery, like removing part of the liver, going for a kidney transplant, you want to be screened because you don't want to have kind of a bad event after a big surgery. So it's important to kind of take care of that. And also, if you like to know, it's your right to know. And then also if you have a high-risk occupation like a pilot or other high-risk occupation, it's you owe it to the others that you need to be screened. So if you have, then you get screened. If it's negative, you repeat every 5 years if you're at high risk, or every 10 years if you're not at high risk. If you do find a brain aneurysm, it's not a completely negative, it's not a very bad news. The reason is, as we follow these patients serially, so when you get a brain aneurysm, it's important to have a follow-up MRI more frequently early on, so every 6 months than every year. It's important to control the blood pressure, stop smoking, control your cholesterol. And then also if you have a very bad headache, the worst headache in your life, you need to head to the emergency department right away. But if you do that, we have shown in our institution at Mayo, we followed a lot of patients who had brain MRIs, about 800 patients, and then about 9.3% of them had an aneurysm, and most of them, they were not that big of an aneurysm, so about 4 millimeters on average. And as we follow up these patients with these serial MRIs, none of them have ruptured. Only 5 of them developed a new aneurysm, and only 8 of these patients had a growth in their aneurysms, and 7 required a preemptive clipping or coiling. So that would be a procedure with a neurosurgeon to make sure that this aneurysm doesn't rupture. So it's, again, this is what I mentioned. It's a good news that if you find it, there's a way to follow and not have a lot of issues from that. And now kind of finishing with a good note is we did a study in Minnesota and showed that PKD patients have exactly the same survival as the general population. So we've come, I think, a long way in PKD world, where even if you have PKD, your survival is similar to anyone else who doesn't have PKD or kidney disease. And that's with a caveat that this is in Minnesota, so trying to have a very good health, that's also important. Healthcare, I mean. Now, in general, what I like to show you quick before we go to the journey with the patient is if you have typical polycystic kidney disease, so both kidneys are big and have a lot of cysts, it's important to get a CT scan, MRI, get your total kidney volume, assess if you are at high risk of rapid progression or at low risk, because then you can get reassured if you have smaller kidneys and you're not going to reach kidney failure. If you're at higher risk, then there's disease-modifying treatments such as GnRQ that I'm sure you're aware of. And then everybody would like to keep them as healthy as possible with the blood pressure control, drinking water throughout the day, keeping the cholesterol under good control, and lowering your sodium and caloric intake. And with that, I'm going to move to the journey with one of our patients, and I'll invite Dr. Sabbagh also to join me. And so let's start with Pete, who's a 15-year-old child or teenager who has a family history of PKD, his mother and grandfather. And so he asks you if, or the parents ask us if they'd like to, if it's important to screen. So we typically don't recommend to screen yet because there's no changes in the management, but we recommend that he would stay under a very good healthy lifestyle and check the blood pressure on a regular basis. And then hopefully in the future, we have more treatments that could start early on in life. And at that point, we would like to screen more frequently and at younger age. But right now, if you're 18 and above, it's important to be screened. That's because there's new treatments and you can slow the disease progression. Now he's 21 and he'd like to, he decided he wants to be screened. So he got a kidney ultrasound and he was found to have bilateral kidney cysts, so on both sides. And then the recommendation was to go to a CT scan or MRI to understand how severe the disease is and to understand what to expect in the future. And also the recommendation was to keep his blood pressure low and to work on his diet and body mass index. He unfortunately is smoking, so we'll talk about that. And then later on, he decided to be on GnRQ or tolvaptan. And then he continues to follow. He's doing very well. He's thriving in life. He found that his mother has an intracranial aneurysm or a brain aneurysm. So we recommended the brain MRA. It's an MRI of the vessels. There was no aneurysm, and then we repeated in 5 years, and then every 5 years thereafter. Then on a follow-up appointment, we heard a heart murmur, sorry for the typo, and then we recommended that he would go to Dr. Sabah. So Dr. Sabah ordered an echocardiogram, and please share with us kind of what you would look for usually in echocardiogram and what is an echocardiogram, Dr. Sabah.
No, absolutely, and thank you for the invitation, and hi everyone. It's a pleasure to be here discussing all this exciting and this excellent presentation, really, an overview on cardiovascular implications of PKD. So, first of all, what is a murmur? Because I see a lot of patients in my clinic saying I was diagnosed with a murmur. Really, a murmur is something that we hear on physical examination. It's not a disease in it by itself. It is a physical exam finding, meaning when we put the stethoscope, we hear a sound of gushing, and usually that signifies that blood is gushing through most commonly a regurgitant valve. So the role of valves really is to basically open and allow blood to enter from one chamber to the other, and then when the heart squeezes, these valves either open or close depending on their location, and it just allows a one-way direction of blood so that blood doesn't go backwards and it just moves from the heart to the body, et cetera, et cetera. So there are different disease entities that would impact the competency of this valve, causing blood to move backwards instead of in the right direction at high speeds, sometimes causing the murmur. This is what we hear. And so when we hear that on physical examination, we order an echocardiogram or an ultrasound of the heart. And this is an examination where the sonographer holds an ultrasound probe. And basically that ultrasound probe shoots ultrasound waves that get reflected off the heart. And then helps us identify the components, several components of the heart, including the muscle of the heart. So that's how we diagnose LVH, or left ventricular hypertrophy, that Dr. Chabib told you about. That's how we also diagnose valvular heart disease. So problems with the valves, the opening and the closing of the valves, either inadequate opening or what we call stenosis, or inadequate closing causing leakiness, and that's what we call regurgitant valves. It also helps us identify congenital heart diseases, so problems in the structure of the heart, so people who are born with holes inside their heart or abnormal connections between cardiac chambers and non-cardiac chambers. And that's that Dr. Chabib and the group showed that that PKD is associated with and you know, please share with us that information. But the echocardiogram also helps us identify that, and that's another source of murmurs.
Thank you so much. And so Pete has a mitral valve prolapse, and we decided just to kind of follow up on that with making sure that if the symptoms occur, other symptoms like feeling short of breath or what have you, then to follow up with additional echocardiograms and follow up with a cardiology clinic. Then he continues to kind of grow. So Pete is now 43. His kidney function is now 52. That's the GFR. So we follow something called creatinine, which is a blood test that tells us how the kidneys are working. And he's at chronic kidney disease stage 3A. So there's 5 stages of chronic kidney disease. One is normal. Everyone with PKD has stage 1 because they have abnormal anatomy of the kidney. And then as the kidney function and the kidney reserve declines, they move down the stages. And stage 5 is kidney failure. That's when you start thinking about either dialysis or kidney transplantation. So he'd like to know if there's a way to predict when he's going to reach kidney failure. That's a very important information, and that's very sensitive and kind of emotional information to get, but it's important to get that. So then you decide to send him through the PKD platform, or something that we are working on at Mayo Clinic, where anyone in the world can have an expert opinion from us. They can upload their clinical information, their CT scans, MRIs, and hopefully in the future we can also have the urine and blood sample and genetic information. For now, we're mostly focusing on the clinical and the imaging. And then the hope is to have a bioregistry, and then for this particular patient, like Pete, to kind of get through the platform where we can look at their images, look at the clinical information, and provide back an information where we kind of tell them if they truly have Adpkd, how severe the disease is, when to expect the kidney failure to be, and the kidney failure onset. So for him, we looked at the total kidney volume, and we adjusted that by their height and by his age, and we identified him as Mayo Class 1C. So he is at risk of rapid progression. He's already progressing, where we see his kidney function low, so it's at 52% or ml per minute. And through the Mayo imaging calculator, we were able to predict that he might reach kidney failure in 19 years. And that's not the best magic ball or kind of prediction. So there is some error to that, but at least gives you kind of a good average or good prediction. So he decided that he's going to take everything under control. So he lost weight. He went into a good BMI. He stopped smoking. He was a little bit pre-diabetic to diabetic, and he controlled his sugars. And he made sure that he's always compliant with his medication and medical plan, because it's important to take care of yourself. So at the time when you're going to need kidney transplant, the team is confident that you're going to take good care of yourself and the gift of life that you're going to receive. So it's important to really be truly compliant, not because of just compliance, but also because of that's the best outcome you're going to have, and cherish the gift of life you're going to receive. And also he adjusted all his kind of financial and medical coverage plans, so it kind of fits where once he's declining kidney function, he has good support from his family, his business, his medical insurance, and what have you. Then he reached around 60, a GFR of 20. And this is the time when you and your provider should consider going to a kidney transplant evaluation to be on the wait list. And so usually what we do is upon referral, we usually do a stress test. And that's kind of a very common and very usual test that we do before getting on the wait list. And Dr. Sabah will explain to us why we do a stress test. And I know we're running a little bit out of time, so we'll move a little bit faster, but we'll get kind of a good idea of what that is.
Yes, absolutely. So just two basic and important statistics. Coronary artery disease or blockages in the blood vessels that feed the heart are one of the most common causes of morbidity and mortality in patients awaiting kidney transplantation. And it is the #1 cause of death. And so #1 cause of death in patients who have received the kidney transplant. So aggressive screening for coronary artery disease and risk factor mitigation, just like Dr. Chabib mentioned, is very, very important. And the way we screen for coronary disease is first we meet the patient and discuss whether or not they have symptoms, right? Common symptoms include chest pressure and shortness of breath. And depending on the risk factor profile and the symptoms, we then decide to proceed with stress testing. And there are different types of stress tests, but the basic principle is that we want to stress the heart, meaning we want it to pump quickly or rapidly and work it so that it unmasks these blockages that declares itself on the stress test. So basically, the most common stress test is an exercise stress test, meaning that we ask the patient to stand on a treadmill and walk, and then it ramps up gradually, and then we have hooked to their chest an ECG, so an electrocardiogram, to look at the electricity of the heart, which again, if there are blockages in the blood vessels that feed the heart, there are changes that we see in the electricity of the heart. A lot of times we also add an imaging modality to the stress test in order to visualize changes in the heart with exercise that would also give us more information on whether or not there are any blockages indirectly, such as the nuclear stress test or an echocardiogram ultrasound of the heart. And this is basically what we're looking for, is these blockages, which are plaques that form in the wall of the vessel, and they gradually grow. They can behave in two fashions when they grow. They either keep growing and then people start having chest pain with exertion, or they basically rupture or burst. And you can see here there's a clot that forms on top of it. And those are the people who have chest pain at rest. And that's what we call a heart attack or myocardial infarction. And so that's why we aggressively screen for coronary artery disease. And if there are any concerning findings on the stress test, or what we call high risk features that we identify on the, how far the patient did on the stress test or not. We then take them to the cardiac catheterization laboratory and do what we call a coronary angiogram, where we take a catheter, which is that slender structure, and hook it to the blood vessels that feed the heart and inject contrast or dye into the blood vessels that feed the heart and identify blockage. And in certain situations, we proceed with stenting, where we just put a wire across that blockage, balloon it a little bit to create space. And then here you can see it, just see the ballooning part of it to create space. And then we always put in a scaffold called a stent to push that blockage to the side and just keep that artery open and improve the blood supply. And this is an example, real life example of a coronary angiogram.
Thank you. All righty. So I know we're running out of time, so I'm gonna skip quick on those, but I'll just kind of to give you other ideas, and I'm sure you're aware of these things. So it's important to try to get a preemptive kidney transplant. So if you have someone who's able and willing to give you a kidney, that's the best way, is to do a living donor kidney transplantation. And the best way is to do a preemptive kidney transplant. Since you're being followed closely, you know exactly when your kidney function is going to decline down to the 10%. And then at that time, everybody is approved from the recipient, so the patient and the donor. And then they receive the kidney donation and the transplantation. Now, if the donor is not a good match with the recipient, there's a way called kidney paid program. As long as there's someone willing and able to donate a kidney, then there would be a lot of swaps. It could be up to 10 pairs or even more among many centers. And a lot of times it will happen where you will get a kidney transplant, even if you're incompatible or high risk match type of thing. And then, so maybe we'll skip that just to allow the couple of questions. And again, as a providers and as Mayo Clinic, we are in this journey together with you, and we appreciate your trust in us, and being in many clinical trials and seeing you all the time in the clinic. It's definitely an honor and a privilege. So thank you. And with that, maybe we can take a few questions. Sorry, we ran a little bit out of time. So.
That's okay. I think we'll get a couple in. Thank you so much. That was a wonderful presentation. One question we have is, does a family history of both PKD and heart issues imply an increased risk for heart issues?
So having a family history of heart issues, does it increase risk of heart issues? Not necessarily.
In PKD patients, a family history of PKD and heart issues.
Yeah, not necessarily. So the studies have shown that anyone with a mutation of PKD, so having those polycystins being abnormal, then they are at high risk. There's no particular association, except if there's like non-dilated, non-ischemic dilated cardiomyopathies. So those are rare things where the heart is more kind of dilated, and it's not because of heart attacks and heart disease. Those are somehow inherited, so there might be connection, but not in the general sense.
Are PKD patients at higher risk of needing valve replacement?
So given that they're at high risk of having aortic valve regurgitation, mitral valve prolapse, and tricuspid valve regurgitation, I would say yes. And Dr. Sabbagh, would you agree?
Yeah, absolutely. I agree. It's a risk factor for valve degeneration, and so now I'll tell you that disease progression is variable even with the risk factors, but it does predispose for valvular heart disease, and with that comes that associated increased increased risk of needing valve replacement down the road.
Interventions.
Yeah. Okay, I'd like to squeeze this one in. Looks like we have about a minute. We had a couple of questions about salt intake. Mm-hmm. So what is your recommended daily amount of sodium for PKD patients? And also, if you're on tolvaptan and your blood work is showing that your sodium levels are low, do you still recommend a low sodium diet?
Excellent question. So those are two separate things. So in general, we recommend 2,300 milligrams of sodium intake per day. So that's kind of not a target, but kind of staying below that. Now, as everything in life, if you go in the two extremes where you really restrict extremely low, then there might be an issue. So it's like a J curve. So, but it's important. It's very hard to restrict salt. So when we say less than 2,300 milligrams, typically it is challenging to reach that. So we say 2,300 milligrams. Now with tolvaptan, it's a different story. So when we do see the serum, the blood sodium low in the blood on the blood test, that's not related to how much salt we're eating, although there's some connection. But for the most part, low sodium in the blood means that you have excess fluids in your system in a way that you're drinking more than you should. So sometimes so many of our PKD patients, we've been always recommending drink a lot of fluids. So they've got into that habit. So when you drink a little bit more than what your kidneys can handle, so if you have a lot of water that you're drinking, the sodium level is going to drop. So you just need to readjust a little bit by drinking a little bit less. And tolvaptan in general makes the sodium go up. So that's why we tell our patients to drink more, because they need to make sure they respond to their thirst sensation. But sometimes they drink a little bit more, and that's why the sodium drops. So basically, for that second question, you just need to back off a little bit on how much fluids you're drinking.
Okay, I know that we're at time. I'd like to squeeze one more question in. And if you need to go, that's okay. There's a 15-minute break between this one and the next session. We have a question about LDL. So when you're looking at LDL, what are your recommendations before starting a statin?
So our goal is less than 100, but I will defer to Dr. Sabag. Also, he's an expert in that too. When would you recommend to start a statin?
Yes, absolutely. So when I see patients, they usually have coronary disease or blockages in the blood vessels that feed the heart. The recommendation currently is less than 70, actually. So it goes from 100 to less than 70. And then the Europeans are lowering that number more and more. So we're becoming a little bit more and more aggressive to that. They're almost at 40. So we are very aggressive. To summarize, we're very aggressive about lowering the statin. If there's coronary disease or evidence of coronary disease, using risk factor scores, or the coronary calcium CT scan that we sometimes use in patients who have intermediate risk. If there's evidence of coronary disease, then we just go less than 70.
Okay. And can you clarify really quickly, what did you say the LDL cholesterol number should be?
Less than 70 for coronary artery disease and 100 for those who don't have coronary disease.
Yeah, there's some clinical trials showing, especially in kids, that if you start a statin, the kidney growth might be a little bit slower. But if someone has heart disease, it's important to be more aggressive, as Dr. Sabag mentioned. So if you have higher than that, let's say 110, 120, 130, and you're not able to bring that down just by avoiding the dietary, so trying to do lifestyle modification, then we have low threshold, and in other words, would be aggressive to start a statin.